Hello, everyone, and welcome to our webinar today, Mental Health Care for Blind Clients, New Ground and New Perspectives. This webinar is sponsored by the Northeast and Caribbean Mental Health Technology Transfer Center, or the MHTTC, and we're housed at the Rutgers School of Health Professions in the Department of Psychiatric Rehabilitation and Counseling Professions. My name is Kati, and I'm the project coordinator of this center. And I will be introducing our center as well as our esteemed speakers for today. Next slide, please. The MHTTC is funded by SAMHSA, the Substance Abuse and Mental Health Services Administration, to enhance the capacity of the behavioral health workforce to deliver evidence-based and promising practices to individuals with mental health conditions. We also address the full continuum of services spanning mental illness prevention, treatment, and recovery supports. And we provide training-related workforces to provide effective services to people with mental health conditions. We also utilize supplemental funding to support school teachers and staff to address student mental health. Next slide, please. As a reminder, all of our training programs featured on your screen, as well as the products and services we offer, are available to you at no cost. Next slide, please. Following this webinar, you'll be asked to complete a brief survey. We value this feedback and use it to improve our activities and inform our future training programs. We thank you in advance for your feedback. Next slide, please. We also want to let you know that this webinar is being recorded, and we will post the recording along with the presenter slide within 7 days of this webinar broadcast. At the time of this presentation, Miriam Delphin Rittman served as Assistant Secretary for Mental Health and Substance Use at SAMHSA. The opinions expressed herein are the views of the speakers and do not reflect the official position of the Department of Health and Human Services or SAMHSA. No official support or endorsement of DHHS or SAMHSA for the opinions described in this presentation is intended or should be inferred. Next slide, please. As a reminder, the MHTTC network uses affirming, respectful, and recovery-oriented language in all of our activities, products, and events. Next slide, please. We also wanted to let you know that the new 3-digit dialing code for the Suicide and Crisis Lifeline is now available. 988 is not just a suicide crisis line. It is for people experiencing a suicidal, mental health, or substance use crisis of any kind, or any kind of emotional distress. It's also for people who are concerned about someone experiencing a crisis. You can connect by calling or texting 988, or you can chat online at 988lifeline.org. Calls, texts, or chats are responded to by a trained crisis counselor. Next slide, please. Now let's begin our webinar. We have Julie Grutzmacher, Dr. Siobhan Polian, and Dr. Connie Hills with us today. Julie is Director of Patient Advocacy and Public Health Initiatives at Prevent Blindness. She holds a dual master's degree in social work and public health and has more than 20 years of experience advocating for equitable access to and delivery of healthcare services. Julie's work has led her to the Peace Corps in Sub-Saharan Africa, academic medical facilities, federally qualified health centers, academia, and nonprofit organizations, servicing communities impacted by HIV/AIDS, premature and low birth weight babies, and high-risk pregnancies. She has experience in building, implementing, and evaluating educational training programs from scratch, first in academia with medical residents, and then at Prevent Blindness with the ASPECT program, designed to strengthen patient empowerment efforts for the visually impaired and blind and their allies. Julie is passionate about her work to reduce barriers to eye care and to optimize health, including mental health outcomes amongst persons who are blind or low vision. Dr. Siobhan Polian is a St. Lucian national who holds a doctoral degree in vision science from the University of Alabama at Birmingham. Her research focuses on the impact of social and behavioral factors on disease management in glaucoma and other chronic diseases. She has a strong passion for advocacy and was the recipient of the 2021 Prevent Blindness Rising Visionary Award. In 2023, she was also recognized by the Association for Research in Vision and Ophthalmology and received the ARVO Emerging Advocate Award. She is determined to improve overall eye health by directly addressing the social, behavioral, and psychological barriers that limit access, delivery, and the uptake of eye care resources. In addition to her research, Siobhan serves as a mental health intern with Prevent Blindness, where she explores the impact of visual impairment and blindness on mental health and psychological wellness. We also have with us Dr. Connie Hills. Dr. Hills is a consultant, speaker, and psychologist with 30 years of experience providing clinical services, teaching, and research in the field of mental health. Utilizing a mind-body framework is a central theme in her work. She holds a Master's of Arts degree in mental health counseling and a PhD in clinical psychology, and is a licensed psychologist in the state of California. She has been living with age-related macular degeneration for 10 years. She is also a mental health intern with Prevent Blindness, where she helps work to build bridges between the mental health and blind community. I want to welcome everyone, and I will turn it over to Julie.
Thank you so much, Kati, and thank you to MHTTC for this wonderful opportunity to present on such an important topic. So I'm so glad to be here today. The title of our webinar is Mental Health Care for Blind Clients, New Ground, New Perspectives. I am a white woman in my early 40s. I have long, curly, thick brown hair, and today I'm wearing a red shirt. So for those of you who are unfamiliar, that is an audio description of myself, and that is something that can be very helpful and inclusive for the visually impaired and blind community while speaking. So all of our speakers today will do an audio introduction as well. And that might be something that would be of interest to you all on the call, to think about incorporating that into your practice as well. So the learning objectives for today include to define core concepts to empower blind people, discuss the development of Prevent Blindness mental health modules, a little bit on the background of the need, the content that's included, the format, and our goals for distribution. We'll discuss how research findings on quality of life among blind people can help mental health providers conceptualize treatment approaches, and we'll describe considerations when seeing blind patients for psychotherapy, counseling, or medication management. So we'll take the objectives one by one. So starting with to define core concepts to empower blind people. I want to define a few different paradigms as well as some concepts. So to start, I want to define disability, and then we'll move into the medical model of disability and the social model of disability. So what is a disability? A disability is a physical or mental condition which has a significant long-term impact on your ability to do daily activities. A significant long-term impact on your ability to do daily activities. And the medical model of disability frames disability as bad. This is a paradigm that is a little more outdated, but it's pervasive. This is definitely the dominant paradigm throughout our culture. And it's sort of the idea that the person with a disability needs to be fixed, that the problem lies with that person. And it's a mentality of cure culture, CURE. So it can be considered paternalistic. And it is useful, on the other hand, when it comes to really innovating and developing new treatment, particularly for acute conditions. The social model of disability, on the other hand, frames disability as good. It asserts that the built environment is really the problem that needs to be fixed, and not the individual who has an impairment or a disability. And that the disability only results from the way that society is structured, and how it might disadvantage people who have impairments. The social model of disability can be very useful when it comes to promoting social and structural advancement. Ableism. So ableism is a set of beliefs or practices that devalue and discriminate against people with physical, intellectual, or psychiatric disabilities. And it often rests on the assumption that disabled people need to be fixed in one form or another. And some general examples of ableism that show up in our society include doorways that are too narrow to accommodate a wheelchair, buildings without elevators, restrooms without handlebars, and restaurants with menus with small font and gray letters. Another really important concept when it comes to mental health and identity is internalized ableism. So this is the act of people with disabilities imposing society's ableist standards on themselves, believing the messaging that society sends, whether explicitly or implicitly, as truth. So this can show up as the sense of not wanting to be a burden, feeling like you don't fit into the disability community, feeling that you don't deserve accommodations. And when emulating the norm, the disabled person is required to embrace an identity that is maybe not their own. On this slide, and I would encourage you to pause for a second, and if you're comfortable, close your eyes or maybe sort of soften your gaze. And as I read these statements, consider how it impacts your own beliefs. So these are some examples of ableist beliefs about blind people. Blind people can't cook or play sports. Blind people are more accepting of physical appearance of people they date. Blind people see total darkness. Blind people don't fully understand words like see, view, and look. Blind people have superior hearing. Blind people are unable to live independently. Blind people wish they were sighted. Blind people can't be good parents. Go ahead and open your eyes if you close them. And just to consider how these statements might be true for you, if you believed them at any point. I know for myself that prior to working at Prevent Blindness, starting 4 years ago, I definitely believed, if not all of the statements on the screen, most of them. And that is okay. It's not okay to believe those things but it's normal to have been fed those messages. So it's important to recognize that these are ableist beliefs and perceptions on what is possible for the visually impaired and blind, which is why 4 years after working at Prevent Blindness, I know differently from hearing so many different stories. want to talk a little bit about language and its impact on mental health and identity as well. So earlier this year, there was an author from the organization called Be My Eyes, which is an incredible organization. They have a great app that connects visually impaired and blind individuals to sighted individuals to carry out various tasks at hand. And this author published what was it's considered to be kind of guidelines for language, preferred versus non-preferred terms. And I bring it forward because I think it is so important to reflect on the language that we use. And I'll read the words that are on the screen, but before doing that, I want to point out that I have brought these guidelines to the community at Prevent Blindness, to the Aspect community, which you'll learn more about. And the reflections of this group is that there's no consensus, that it is very individual what some people prefer and other people don't prefer. So we'll go through them but it's important to keep in mind that as a best practice, it's really good to ask how people prefer to be identified and to be ready to apologize where needed and to correct your language as well. So, so some preferred language, as this author asserts, is that people who are blind people or people who have low vision or disabled, that those are preferred terms. The first few are, so people who are blind is an example of person first language, and blind people is an example of identity first language. So some people prefer person first, others prefer identity first. Some non-preferred language that this author suggests is visually impaired is not preferred, partially sighted, partially blind, handicapped, differently abled, totally blind, visually challenged, physically challenged, suffering from, or special needs. And I want to just touch on a few of them and the reason that he encourages folks to not use this language. One is the differently abled. So he believes that this is euphemistic and that and discourages its use because it doesn't, it's trying too hard to be nice. Suffering from, he writes that this is a connotative value that the person is placing on the individual with an impairment or low vision or blindness. So I bring these forward just to say that, again, I think it's really important to ask. And we, the presenters, will use certain terms. I've heard from the feedback I received from the community was that visually impaired was okay to use for many people. So we will use these terms, but I think, all to say that it's important to reflect on your own use of language and the impact that it can have on mental health. Okay, so moving into learning objective 2. This is to discuss the development of the Prevent Blindness mental health modules. On this screen is a picture of the Aspect community that was taken in May of 2024. So just this past May, when we convened the group of alumni together for the second time ever. And in the center is a sign that says Aspect Patient Engagement Summit 2024. And I am holding the sign, and on the other side, holding the sign is another Aspect alumni. And it's about, I would say, 60 people in the picture. And so these are all Aspect alumni. So what is the ASPECT program? So ASPECT is an acronym, and it stands for Advocacy, Support, Perspective, Empowerment, Communication, and Training. This is an advocacy training program that started in 2020. And I was hired to start the program. To date, we have trained about 200 individuals from across the US and New Zealand and Canada and other countries as well. It is a 10-session educational series that's held on Zoom, and it brings together a really diverse group of people, including eye doctors, medical students, parents, individuals who have a variety of eye conditions and some vision loss and blindness, mental health providers, occupational therapists, and many more. And we come together to learn about advocacy and to focus on storytelling as a really, really powerful tool for advocating. So it was in the ASPECT meetings that again and again throughout the various cohorts, the topic of mental health kept arising. Stories of individuals receiving a diagnosis and not receiving very much in the way of support or resources or just validation. And by contrast, they would share stories of being diagnosed with cancer and, working through that treatment and immediately being connected to wraparound services, where by contrast, it wasn't the same. It wasn't true when they were given a diagnosis of a blinding eye condition. And so I knew, and I started to prioritize based on my background. I was trained as a medical social worker, worked in many different settings as Kati had shared with you. And it will always be how I approach all of my work. And so I knew that there was an opportunity for us at Prevent Blindness to do something about it. And the leadership was very supportive. So in 2022, in the summer, we convened a multidisciplinary task force. The mental health task force is what we called them. And we gathered people who are in our network. Many of the ASPECT alumni participated, some of whom were mental health providers and also had vision loss. Some were ophthalmologists and retina specialists and optometrists and low vision specialists. And we had mental health providers and so we all came together for a total of 4 meetings. Each of the meetings were held over Zoom. They were an hour each meeting. And we talked about what were the barriers to talking about mental health within the clinic setting, between patient provider. What gets in the way of patients expressing that they could use help, that they need more resources, that they could benefit from connecting with another patient? What gets in the way of doctors referring their patients to various mental health services, to asking about mental health in the first place, how they're doing, how they're coping, what their support network is, what gets in the way? And so in all of these conversations, we really uncovered many important components and findings, and we summarized all of this. It took us about a year to put this all together and organize the content. But a year later, we published what's called an issue brief. And this is a report that is really geared towards policymakers, public health professionals, and more, and providers. And what we found were that there are key barriers. So 5 key barriers to these conversations happening in the first place. So the key barriers are awareness a really lack of awareness on the part of eye care providers, knowing what mental health services are out there, both locally or nationally, and then being able to refer because of that lack of awareness. A limited time, not having time to bring it up, a shortage of trained providers, specifically mental health providers who had expertise or special training in counseling, those with vision impairment and blindness, the stigma, and that can be on the part of the provider, having in stigma and not bringing up the point or anything about mental health in the first place, the patient not bringing it up related to stigma, and just and the wider society. And then lack of referrals as well was the fifth barrier that was identified. And the group specified that this was really about an insufficient referral system from providers, specifically ophthalmologists or retina specialists, to vision rehabilitation, which could, and in many cases does help to not only provide skills, but also in many cases support mental health support. But we decided to start and focus on the shortage of trained mental health providers because we really identified that there wasn't a lot of work being done in this arena. Well, and that, you know, there needed to be more. And that it's going to take all of us. We recognized and we heard so many stories about people with low vision and blindness starting therapy and then stopping because the therapists, you know, just really didn't get it, or they couldn't identify, or, you know, they made the patient feel, you know, undervalued, or, you know, just not validated. And so we knew that there were many more cited mental health providers out there that could benefit from this information. And so that's where we decided to start. And we brought in, thankfully, Dr. Connie Hills and Dr. Siobhan Polian, who both went through the Aspect program, were willing to join me in this effort. And it has been a fun journey so far. So we decided to start with really capitalizing on the expertise within the Aspect community and uplifting the stories. So as I mentioned, the Aspect program is all about using your own story for change, social change, whether that's changing policy or changing minds. And so we sent a message out to the Aspect community and asked for stories. And people really came back in a very robust manner, responding, I would love to share a story. I have a story. I have something to say on this topic. And so Dr. Hills and Polian, they really led this effort in hearing those stories, in synthesizing the material, in identifying themes, and we let them tell us what was important. And from that, we came up with 4 modules, training modules. And these modules are in the form of videos. So each module is about 15 to 20 minutes long. These are currently in the editing phase. We recorded all of the stories. So each video has at least 1 or 2 stories, but some have, you know, 4 or 5. And we're allowing the stories to underscore the points, the objectives, to really drive home the importance of this topic. What could be improved? Where are the gaps in care and delivery? And so we're excited to be able to share these videos when they are available, and we're hoping that they will continue to be used, you know, for CEU and professional development. And we'd love to partner with other organizations. We've talked to a few wonderful organizations already who have wonderful platforms where, you know, all of you probably already know about them, can go online and review these videos and receive CEU credits for it. So we're hoping that these modules will live on one of those platforms. And so the first two were led by Dr. Connie Hills. They focus on, the first module focuses on accessibility as a clinical issue. So all of the things that get in the way of a person with low vision or blindness even getting in the door of a therapist's office, paperwork, inaccessible, just structural barriers, about the office itself, things like that. So acknowledging that as part of sort of an ableist cultural, barrier. The second module is the blind-centered approach to counseling and therapy, which we believe could be a whole other webinar. And for today, Connie will focus on the content of the first module, or at least in part about accessibility. And the third and the fourth modules are about vision loss and its impact on the family and the wider society. And those were led by Dr. Shervon Polian. And so speaking of Dr. Shervon Polian, at this time, I will now turn it over to her.
Thank you, Julie. Hello, everyone. My name is Siobhan. I am a Black woman. I'm currently wearing a beige sweater or white, and my hair is pulled back. I'm a sighted individual. I'm currently wearing glasses. And as was mentioned in the introduction, I'm from St. Lucia. I work as a clinical researcher at the University of Alabama at Birmingham. But for a long time, I was also a caregiver for a blind individual. My dad lost his vision after being diagnosed with glaucoma for some time. And so I kind of put everything on the back burner and I moved back home to be his full-time caregiver. But through his experience and through my own experience, I really discovered a passion for patient-centered care and advocacy. This was my dad's experience, but I knew that there were a million other people who were just like him. And I wanted to create a change and make as much of a change as possible moving forward. But today, I will spend a few minutes discussing a very important topic, which essentially is quality of life and mental health in blind individuals. And we'll also talk a little bit about how research findings can help mental health providers or even caregivers to better conceptualize treatment approaches and maybe even identify the needs of our loved ones. So vision loss has a profound negative impact on mental health. Most people that we talk to will agree, even some of us will agree, that blindness is probably the worst thing that could happen to us. Worse even than becoming paralyzed. I just saw the chat. Than becoming paralyzed or even having cancer. But besides that anecdotal evidence, of just talking to each other, research shows that blind individuals are almost 3 times more likely to develop depression. And a study in 2021 found that almost half of all individuals who are blind experience depressive symptoms. So even if they didn't have full-on clinical depression, they experienced mild to moderate depressive symptoms. But depressive symptoms and clinical depression is not where it all ends. Individuals often experience many complex emotions, so feelings of shame because they might feel like they are the cause of the blindness. It was something they did. Loss, just grieving for all of the things that they may not be able to do anymore, that grief and that loss. And with that grief and loss might come social withdrawal, just becoming much more withdrawn from your support network and your friends and family. And then loneliness, profound feelings of loneliness. Research does show that persons, especially older individuals who are blind, experience very high levels of loneliness. And all of those feelings put together may lead individuals to resort to whichever coping mechanisms will help them to get by in the moment. And then in the absence of the right type of support, those coping mechanisms can be unhealthy in the long term. So I have a quote here on the screen from one gentleman who lost his vision. And he said that when I first lost my eyesight, I never had emotional support. My way of coping was hitting the drinks, hitting the drugs, and going crazy. And I'm pretty sure that that experience is not unique to him. After experiencing such a change in your life circumstance, many of us and many individuals may just try to deal as best as we can and cope as best as we can. And unfortunately, when we don't have the type of support and the resources that we need, those coping mechanisms can be things that may be harmful in the long term. But in addition to the impact of blindness on mental health, blindness and vision loss also impact our quality of life. So our perception of our position in life relative to our goals and values. I have some additional quotes here on the screen, as well as a graphic that shows some of the dimensions of quality of life, some of the things that help us to feel good about where we are in our lives. So feeling healthy, having a good financial well-being, belonging to a community, having a stable job, personal safety. All of these help us to be more secure and have good quality of life. But blindness impacts each and every one of those dimensions. So on the left here in the first box, this individual says, it very nearly, I think, cost us, my wife and I, our marriage because I was quite unpleasant on more than one occasion. So this individual lost their vision, became blind, and that affected his relationship with his closest partner, his wife, to the point where it almost cost them their marriage. Another individual was quoted as saying, it stopped me from going out straight away. I was in for the first 2 years, almost the first year and a half. So after becoming blind, this individual no longer felt secure enough to go outside and interact with their environment. And they effectively became a shut-in for almost 2 years. This other person, I got quite narky with people. If I was out with my stick and they'd bump into me, I'd get angry with them, like it was everyone else's fault. So feelings of anger can also accompany the loss of vision, and that can negatively impact quality of life. And this final gentleman, who's speaking about his career and his ability to work and be productive, at the bottom here, in the bottom quote, says, all of that experience is shoved right back in your face. You're a broken toy now. And what happens to broken toys? They go to the dump. So suddenly the loss of productivity and all of these things may have a really, really negative impact on individuals' quality of life. And I found that this was true in my dad's experience. He was always a highly independent individual. He was an electrician, he was a fisherman, he did it all. And once he lost that vision, it seemed that all of these things that brought him fulfillment and satisfaction, it felt like they were taken away. And he became very depressed, very withdrawn. He would still try to, clean fish. And, we know that that requires the use of tools like a very sharp knife, a fish scaler. And we had to, try to get him to understand that he was no longer, he needed additional tools. He was no longer able to carry out those functions as he did before. One thing I do remember, one day we were redecorating the house, and my mom and my aunt and all of us, we were all at his house, and we were moving things around and changing the carpet, and we were having a good time. But my dad, even if it was his home, he was not part of that. He was shut up in his room, not able or willing to laugh and enjoy the moment with us. And that's something that stayed with me, still stays with me now, just a level of isolation that he experienced. Even in moments where we would try to bring him in, the marked impact on his mental health that he experienced after losing his vision posed a very, very big challenge. And there was just all of a sudden such a vast distance between us and him. And his mental health did decline very greatly. And unfortunately, at that time, we were not as equipped to provide the level of support that he needed. We didn't know what we were doing at all. And even in our home country of St. Lucia, it was a little more difficult to access some of the mental health resources that would have been so beneficial to him. And so that's just a little bit of my experience with my dad and how I recognize that this is not his story alone. This is the story of so many other people who have lost their vision and now need to navigate a different reality. Now, whether we're in a setting like I was at home, where health resources were a little more difficult to access, or whether we're in a different setting where mental health support is more available, there are still factors that can make it very hard to tap into some of these resources. And one of these factors is age. So the loss of vision, however old you are, can be extremely stressful. But that can also be very stressful as if that loss of vision occurs when individuals are younger. There may be feelings, in addition to feeling angry, there may be feelings of being robbed of a normal life, quote unquote, or even a future. According to one study that's linked at the bottom, referenced at the bottom, younger individuals who had a sudden change in their vision or who suddenly lost vision and became blind thought that their life was over and they didn't want to carry on. They felt that there was no way out and wanted to give up. So that had a very marked impact on them. Social barriers, Julie spoke about that a little earlier. Shame and stigma may also hamper efforts to seek support or use helpful resources that may be readily available. In the same study, one individual reported that he was assaulted after he was out in public and he was using his cane. He accidentally bumped into someone else and they took a look at him and he did not fit their idea of what a blind person should look like. And he was assaulted and he stopped using his cane after that. This is something that he needs to navigate his environment, but because of the shame and the stigma, and potentially even the aggression from other people who did not believe him, he stopped using that tool. And this can easily apply to mental health support as well, not just physical tools like using a cane, because there's still so much stigma around receiving mental health support. Another factor, in addition to age or personal circumstance and societal factors such as stigma, just unavailability of these resources is a major factor as well. In this same study, younger servicemen in the UK military who had lost their vision really tried to cope with their loss by escaping through substance abuse and also even through making suicide attempts. And so, all of this is just to highlight the profound need for mental health support among blind individuals, and also to couple that with the limited availability of those resources, like Julie mentioned when she presented the slide on the mental health task force. So next slide, please, Julie. So we know that we have a twofold issue. One, there is a very profound need, but at the same time, that need is coupled with limited availability of some of these resources and the support. And we know this because research tells us this. So for example, in a study on patients who have age-related macular degeneration, almost 91% of them reported that they did not receive any mental health support, even though they mentioned that many of them experienced high levels of anxiety and depression. And in another study, approximately 30% of blind individuals who qualified as mild to moderately depressed. However, none of these patients received mental health support. And there are many reasons for this, but one of the key reasons that we will latch on to is the shortage of mental health providers who have the training or experience working with these individuals. And that's part of what we're trying to accomplish today, get the messaging out there so that over time, more individuals will seek out that training because it's definitely needed. In fact, in a 2004 survey, mental health clinicians who were surveyed rated blindness as one of the most difficult conditions for them to treat, simply because of a lack of training in that field and a lack of funding. So this is really one area that we hope to make significant inroads in. And this is just a first step with the group that we have on today. Just building that awareness is always the first step to taking any course of action. And we know that addressing the disparity between the need for mental health support and the availability of those resources, that's not something that we would be able to address in one afternoon. That's going to take systemic change at the very least. But there are a few approaches and considerations that we know have helped patients to achieve or even work towards better mental health, quality of life, and personal empowerment. And so in lieu of the systemic changes that do need to occur, I'm just going to talk about 3 considerations that might be helpful as we work towards these goals. And the first one of these considerations is understanding the circumstance. So just the circumstance around the individual's, the loss of that individual's vision, what that was like. So much like these 3 glasses that I have, and this is Connie's picture. I love this picture so much, and I thought it was a really good way to summarize the information on the slide. Much like these 3 glasses, they all serve the same function, but they are unique, very unique. Personally, I like the one on the right. The color transition is very beautiful. But stepping away from the glasses, they're pretty much just an allegory for the fact that individuals can lose their vision under totally different conditions, and those circumstances can influence the way in which they cope with the loss of that vision. So blindness can be congenital. It could be something that happened very early after birth. It could be progressive over the course of several years, or it could be very abrupt and trauma-related. And as a result, one's relationship to their diagnosis and the stages of coping that they cycle through will also be very different depending on the circumstance. So, for example, let's look at someone who was born blind or who lost vision at a very, very early age. That person's identity as a blind individual begins very early in their life. After that initial stress of discovering that this individual is blind, that person moves into adulthood and they tend to have coping skills that are very well established because this is an identity that they've had from very early on in their lives. However, that loss of vision may play a much bigger role on their family members, for example, their parents, who have to help them at a very early age, perhaps they're 1 at the time of the loss of vision. That stressful experience is shared, and a large part of that is shared by the parent. Julie had mentioned that we worked on the modules, those 4 modules that came out of the mental health task force. We interviewed several individuals from the Aspect program, whether they were blind individuals, whether they were caregivers. And one of those individuals was a caregiver or parent of a very young daughter who lost her vision very early on in life. In that interview, her mom acknowledged that she felt many, many emotions. One of those was guilt because she had 2 other children and they had normal vision. They had 20/20 vision, but her daughter had a genetic condition that caused her to become blind very shortly after birth. And that was carried down on her side of the family. So she had feelings of extreme guilt. And she was also very angry because she felt like her daughter was robbed of a future or just a similar life, a similar group of experiences as her peers. And she actually needed a lot of mental health support to help cope with those feelings. And so that's kind of one type of experience or one type of course that an individual can go through based on when the loss of vision occurs. Let's pick a different example. When someone loses their vision more progressively, let's say the loss of that vision occurs from the ages of 20 to 35. So for persons who have more progressive loss of vision, that identity gradually shifts from being sighted to not being sighted. And depending on how fast the loss of vision occurs, they may have time to integrate those 2 realities or those 2 identities and integrate those 2 worlds, going from being sighted to not being sighted. And a lot of the time, their coping mechanism will depend on their personality and who they have been as adults and how they coped as an individual, how they coped as a sighted person rather. And so that initial stress of the loss of vision may not be something that the parent shares in as much compared to the first scenario that we looked at. So in those individuals, there will need to be some training, but in general, some persons may be able to navigate that a little easier because of the time. But worry may also be a bigger issue here because there may be a lot of worry about the loss of future vision, whereas worry may not have factored in as much in a patient who had congenital blindness. And then the last group is individuals who have become blind due to sudden trauma, for example, an accident. So their identity as a sighted person is very rapidly displaced. And now their coping mechanism is going to be tied to how they feel about the incident in general or the traumatic incident in general. Very often, they may also need mental health support, not just to deal with the sudden loss of their vision, but also to deal with the traumatic incident that caused the loss of vision. And for these individuals, navigating this new reality can be very, very difficult. And they definitely may need a lot of mental health support, particularly in terms of their identity. Who am I? Last week, I was a sighted individual. I was an acrobat. I was a gymnast. Who am I now? These individuals may experience identity paralysis, which is essentially where your sense of self doesn't really keep up to your new role or your new situation in life. And that's the need for that person, the type of support and the type of tools that they may be very different from an individual who has congenital blindness or who has progressive blindness. And so understanding that context is very important because it will impact the stages of coping that individuals cycle through and their specific needs from mental health professionals. And this was a very important consideration that really came out of our work with the mental health task force. And so I just want us to keep that in mind. Always be aware of the circumstance because it is very important. The next consideration is, of course, peer support. And peer support is helpful for everyone, no matter whether it's a cancer diagnosis or someone who has just lost their vision. Peer support can help to reduce feelings of isolation because for some of us, I know that is me, one of my coping mechanisms is just I retreat into myself. And having someone else who has gone through a similar experience is something that has been very powerful for me as well. And peer support does help to reduce that isolation. It also provides practical advice on navigating some of the unique challenges that we experience in the constraints of the issue that we're dealing with. And it does help to foster a sense of belonging, especially when our identity shifts from being a sighted to a non-sighted person. We can sometimes feel like we don't belong in this group anymore. Where do I belong? Peer support can can foster rather an environment that can help persons feel and remember that they are part of a wider community. And peer support has been found to be very impactful. It has been found to improve social functioning, mental health, and satisfaction with life, particularly in socially isolated older adults. And when I think about this, I go back to my dad. That's one thing that he did not have. There was no one else in his immediate circle who understood what he was going through or had been through what he was going through. And that's one of the reasons why I think one of the ways in which we were not as equipped to help him deal with this very traumatic incident for him. And peer support can also benefit caregivers, not just patients, not just clients. In another interview with the mother of a blind individual, this parent indicated that it was so hard for her to have a support network, a social network, because she was so devoted to caring for her daughter that she couldn't date because everyone else came second. New partners came second. And she lamented the lack of social support in her life. And she eventually created an online peer support group not only for children who are diagnosed with her daughter's condition, but also parents. And that actually grew very well over the years. She actually had, I think, about 5,000 members in that group on Facebook. And so in cases where persons do not have that support, they might create it for themselves and other people. That's just a testament to how impactful and powerful that is, and that can be. And then the last platform that I would like for us to think about is advocacy, just tying in the Aspect program and how powerful that is. Advocacy can play a transformative role in improving mental health in many different ways. First, I'm going to read some of the quotes on the screen here. So these quotes are all from Aspect participants. So the first one, being blind or having low vision has affected many age groups. We each have a voice. We must tell our stories in order to bring about change and awareness. Another individual says, I realized how valuable it is to connect with others with vision impairment, to both encourage and be encouraged. Advocacy is really a holistic journey and process. It takes a lot of different people with different skills to get there. And in the very last bubble, advocacy motivated me and energized me. And all of these really just speak to how important it is. It can help to establish and strengthen support networks. It can help other blind individuals access essential resources. And lastly, and perhaps most importantly, it can give blind individuals a voice in the decisions that affect their lives and allow them to be more represented in policy making and service planning. And so in short, I just wanted us to keep these things in mind, namely that blindness and the loss of vision has a major, almost undescribable and unquantifiable impact on mental health and quality of life. And that unfortunately, there is still a major unmet need for mental health professionals who do have that experience working with blind patients. For professionals who are seeking out training, seeking out training is one way to narrow that gap. But until then, there are a few other considerations that can help us in the clinic. And I just want to leave these with you. So remember that individual characteristics and the circumstances around vision loss can affect the course of treatment. Also, it is important for us to gauge individuals' adjustment, where you are in your vision, in your journey of navigating this new reality. Understanding where they are and what their needs are might help us to identify the strategies that may be best for them. So it's always important to ask and get as much information from them. What do you need? Tell me about when this happened to you. And then lastly, discussing needs, preferences, and goals. That's a very important way for building trust and partnership among mental health providers and professionals and the clients who come to see them who do have those needs and who have limited vision, or who are blind. And with that, this is the end of my part of the presentation. We have taken in a lot of excellent information. And so I think now would be a good time for us to just pause and internalize some of the material that has been presented. So we're going to take just a few minutes to do this. However, when we return, my colleague, Connie Hills, who is a clinical psychologist, will lead the last part of the presentation, which will have a slightly different format. There won't be any slides. And in Connie's presentation, she will help us to just integrate all of the information that myself and Julie have presented so that we can use this information in a more clinical setting. So while we're on break, please feel free to enter your questions into the chat, and we will have some time at the end for Q&A. It's now 1:59, so I think if we reconvene at 2:04, that would be good. Julie, any thoughts?
I'm wondering if we should proceed in the interest of time. Why don't we go ahead and do that? I hope you all enjoyed your 30 seconds. Let's continue just so that we have time for Dr. Connie Hills to go through. Thank you so much, Siobhan. And I'm going to stop sharing my screen. Over to you, Dr. Hills.
Okay. Good afternoon. Well, in lieu of taking a break, I just want to say that you've probably taken a lot in so far, and I'm going to try to help you integrate this all into your clinical work. Um, my name is Dr. Connie Hills. I'm a Caucasian woman in my 60s with brown hair and brown eyes. I have on eyeglasses and a red sweater, and my screen background is a blue sky with a string of pelicans flying by. I'm in San Francisco, California, the unceded ancestral homeland of the Ramaytush and Ohlone peoples. So in lieu of taking a break, let's just take a deep breath together. You can close your eyes. Inhale and exhale. So we have 29 people here left. So for you 29 people, just go ahead and take a deep breath in and another breath out. Okay. So I'm here to support you to make sure that you can comfortably and skillfully see a blind or low vision patient in your clinical practice, which is my main voice. I'm a clinical psychologist. I've provided individual psychotherapy to adults for about 30 years in a private practice setting. I've also worked in many, many other places as I went through my training and internships and licensures. Um, Before I was a psychologist, I was a sign language interpreter. So I got my master's degree after that at Gallaudet University, which is the only university for the deaf in the world. So I've been steeped really in the psychology of disability and mental health for a long, long time. I also am a patient with an eye disease. I've lived with age-related macular degeneration for about 10 years. And for those of you who don't know what that is, I'll call it AMD, age-related macular degeneration. It's a disease that causes damage to the macula. The macula is a round area at the center of your retina, which sits at the back of your eyeball. It's responsible for central vision and color perception. There's two different forms of AMD, dry and wet. So I happen to have one of each, which is not that common. I was initially diagnosed with dry form in both eyes. And then by the way, there is no treatment for dry macular degeneration. There's some proteins that they recommend you take, but there are no medicines. There's some now beginning to have some medicines on the market, FDA approved, but none of them are really successful, if you would. On contrary, there's what's called wet macular degeneration, which I have, and my dry converted to wet 3 years ago. It's called neovascular AMD, and it's when fluid leaks out from abnormal blood vessels under the retina. So they see that it's leaking, they stop the leaking by inserting a needle with medicine into your eye, and then the bleeding stops. So this treatment's been around for about 15 years. And I am a patient that gets these injections. I have low vision. So I kind of come to you with both hats, both being a psychotherapist and also somebody with an eye disease. Going to speak just really briefly about, Siobhan spoke about peer counseling, peer support versus mental health treatment. And as Siobhan mentioned, peer support is immeasurable. It makes you feel less isolated. I have participated in peer support groups. There's a shared experience among the group that is very unique and lovely. The Aspect community provides a big dose of that, which I enjoyed. And there's a lot of laughter and inside humor and tears, and there's just a feeling of being less alone. But sometimes peer support isn't the right place to go over some of your mental health concerns, right? You want to speak to someone privately, or you don't feel like the group is really the right place. I heard some blind people say to me, it's depressing to go to those groups. Everybody's complaining or having a hard time. So you can kind of have to hunt and peck to get the right peer support group. So when somebody wants to go see a mental health counselor, I think it's been well said and established in both Julie and Siobhan's talk that blind people aren't having very good luck seeing mental health therapists, in part because the mental health therapists are not adequately prepared, like we're preparing you right now, or they saw some blind people and they didn't quite understand it or get it. And I've been listening to blind and low vision people tell me over the last few years that their therapist that they saw didn't get it. Okay. So last year in our internship, we made these videos that Julie described. And the first two videos, I interviewed 6 blind and low vision people who had gotten treatment from a mental health provider, mostly psychologists, although some licensed professional counselors, licensed clinical social workers. And I asked them to tell me their stories. We went through a round of several interviews, and at the end of the process, they didn't come up with, but I extracted themes from what they said that really echoed the voices of a lot of other blind people I'd spoken to who saw therapists. These themes is what we're kind of converting into what we're calling best practices. I'm going to talk about 4 of them today. And these are from the mouths of the people that have been there and done that. And it's somewhat reversing we're going from a medical model to a social model now. Okay. So rather than the sighted community doing research and teaching and telling blind people what's wrong or what to do or how they're coping, et cetera, we actually just turned this thing upside down and we said, why don't we ask the blind people to tell us how we can best serve their needs as mental health providers? So the first best practice is what I've called the discovery of blindness. The discovery of blindness. How do you know that a patient who's coming to see you is blind? You haven't seen them yet. You haven't met them yet. You haven't seen them on video. You haven't seen them in your office. They have made a call to your office. They have inquired through their HMO, their insurance. Most of the people that I know get a name of a therapist. We heard, oh, this therapist is really good with this or that problem, or I love their personality, or they've got a lot of experience, or they're the only queer or Black or Latina therapist in town, or sometimes you just get a name and it's got a buzz to it, and so you make a call. Well, maybe the disclosure of being blind comes right out of the gates. So somebody calls and they say, hi, my name is Zoe, I'm blind, and I'd like to see you for therapy. Best practice number 1 is complete. You can move on to best practice 2. But what if they don't say that? So I want you to think about how your practice is set up, whether you're a sole proprietor, whether you work in a group, whether you enter in an HMO, a university, and think about the first person that a patient enters, their name, their address, their insurance, whatever. And I want you to think about the question and include the question right at the beginning, the very, very first contact form. Do you have a disability? Now, Julie talked about language earlier, but this is a very broad, easy yes/no question. It also may be a wide net to bring other information about other patients in. You just say, do you have a disability? They may or may not say yes, but at least you're normalizing it to them, and that's important. Okay? The sooner you know your patient is blind, a big part of who they are, who they identify as, is known. It's not hidden anymore. A lot of these blind people I've talked to say that it's a big part of who they are. They may not talk about it in therapy, and we think that that's probably webinar 2. What do you actually do in therapy when your blind person is there? But the most important thing is that you find out as soon as possible. Because best practice number 2 is how to communicate with a blind person via phone, internet, websites, emails. So again, I want you to think about your practice and how it's set up. These days, it's less about paperwork and it's more about electronic health records. So you're going to ask your patients to fill out questionnaires, medical consent forms, release of information forms, insurance information, and then they send them back to you in order for you to process them to get in the office, right? To see if you can see them. Well, imagine, just for a moment, take 2 seconds. 1, 2. Imagine you're a patient reaching out for mental health care. You're shaky. You're vulnerable. You're not at your best. Now imagine you're blind or you have low vision. And all the correspondence coming from Dr. Gonzalez's office is inaccessible to you. You can't read it. And so what do you have to do? You have to call, reach out, ask to have it be accessible, disclosure blind. Talk about stress. So best practice number 2 is, and I'm sure you do this with sighted patients, you say, how do you prefer we exchange information? Often it's a email or text. Well, this is going a little bit more layered than that. It's how do you want me to send you information? And here's the backstory on that. Each blind and low vision patient handles paperwork differently. Some low vision patients like me, I have magnifiers, I have task lighting, I have Zoom functions to read and fill out paperwork forms and send them back. One blind patient told me she really likes those fillable forms on the computer because she can use her computer software to aim right at where she's supposed to type in on her keyboard, which is accessible to her. Okay. Some blind patients use screen reader software where everything on the screen is being read to them out loud. But mine use screen readers, pick up some PDFs and some don't. Now there's AI software, which is really a game changer. Okay. Well, some blind people use it and some people don't. So it's really important that you find out what their preference is. And the reason is this. If a patient has to struggle, a blind patient has to struggle with being able to fill out forms, these are confidential forms. This is psychotherapy. This is not a shoe repair, right? This is your own mental health. If you're having to struggle, right, and you might feel some of those internal ableist thoughts that Julie had, oh, I feel bad, I can't do this, I have to shamefully say, I can't do this. Everything becomes negative. You know what they're going to do and what they've told me they've done? They've somehow paired all that negative stress and tension with you already because it's your office and you're who they want to see. So your office, your waiting room, your paperwork, everything to get to you is going to somehow now be tainted with that negativity, that upset, that frustration, and you don't want that. I don't think you have to. There's a question, the other part about this is some blind people have questions read out loud to them. So if you or somebody in your office can do that ahead of time, that's good. That's great. Some blind people have family members filling out some of these forms or a friend. But imagine, again, this is therapy, right? Imagine you want to talk to a therapist because you're thinking about having an affair, or you're getting concerned about your prescription drug use and you think you're using too much. You don't really want to tell that to somebody who would help you fill out a form to get your car repaired, right? This is a confidential relationship. And So when they tell you this is how I prefer you communicate with me, this is easiest, this is how I can read things, try to accommodate their preference. I've had blind people say to me that they resented that the therapist did this in the office at the first visit because their staff couldn't do it like everybody else. So I discourage that. You can be creative. And like I said, doing this ahead of time minimizes the chance that the frustration or the difficulty that a blind patient will have will somehow associate it with you, or they'll give up. They'll just say, forget it, I'm not going to go see that therapist. Best practice number 3 is orientation. So what's the first thing we ask our friend or our loved one when they call us? When we say, where are you now, right? Are you at home? Are you at work? Are you at the office? There's a public and private space orientation that we want to have to communicate to somebody, right? Well, many blind and low vision people get what we call orientation and mobility training. It's called O&M. You don't have to worry about M mobility. That's how a blind person gets from their house to your office. Okay, you can just give them directions like you give everybody else in the accessible form. Okay, but what I'm suggesting you do in this step is, if you know somebody's coming to see you, a blind person, I suggest that you ask them if they would like a visual orientation to your building and your office. So say they get off the bus at 333 Broadway, okay? And if they say, yeah, that would be helpful, thank you. So I want you to describe visually what it's like for them to go from the bus to the chair that they're going to sit in when you see them. So that can be, how big is the building, where are the entrances, the signs, the elevators, the stairs, the bathroom access codes. I'm looking at the time, we're going to keep going. We're almost done. If you can't do this, right, have somebody else do this for them. Because again, you don't want your patient to arrive to have not been able to figure that out because you didn't give them that orientation. They're sitting in the waiting room, they have to use the bathroom, they're thirsty, and they're late maybe. You don't want that, right? You want them to arrive like everybody else, comfortable and ready to think about why they've come to see you. The last best practice is a little bit building off of what Julie had mentioned earlier, which is to look inside yourself as a human being before you see a blind patient and ask yourself, do I have some of those ableist attitudes? Do I have that fear of blindness that Siobhan talked about? That's all of which are common in the culture. Have I internalized some of those? My training as a psychotherapist was psychodynamic. So I really do believe that our unconscious biases and strong emotion gets communicated to our patients. And most of the patients that I talk to who saw therapists say that their therapist did not have this in check. And it spilled out into the field. It limited how much they could talk about their lives, their blindness. And some of them stopped treatment. They didn't really get full value out of treatment. So I think just like with any of your patients, you consider your own biases. You can ask yourself the question, how do I feel sitting in the presence of a blind person week after week? Do I know any blind people? What if I became blind? Stand on a street corner, close your eyes for a minute. Get a felt sense of what that's like. And then talk to your peers, talk to your supervisors if you feel like it's a kind of creating static in your ability to be neutral as a therapist. So Julie's going to present a slide right after this with the 4 best practices summarized. So hopefully you didn't have to worry about taking notes. But it is my opinion that blind people should be able to go see therapists just as freely as sighted people. So don't change what you're doing. You know, the best practices are, I think, smart to implement. I think they'll benefit everybody. And I'll end with a reference to one of the books on the book recommendations at the end of this. Stephen Kusitzo, he is a blind poet and memoirist, and he imagines what he calls the planet of the blind, where the sighted world are beloved visitors of this planet. So thank you for listening, and welcome to the planet of the blind.
Hey, thank you so much, Dr. Hills and Dr. Polian. So at this time, I just want to recap all of the great information that Dr. Hills covered. And we came up with a table. The ABCs is what we're calling it. So all of the information that Dr. Hills presented, this is a quick way to remember all of the content, the best practices. So step one is you respond to the blind person who reaches out. And we're saying the A is ask, don't wait. So right away, you want to ask, do you have a disability? Ask, don't wait. Don't make assumptions, be proactive and ask. This invites patients to share their identity as a blind person. Number two is to complete the paperwork. The best practice, the B, be flexible. So ask patients about their preferences for communication and try to accommodate them. This can build a sense of respect and partnership. And you can ask, how do you prefer we exchange information? Step three is to schedule the appointment. This is the C, to convey. Provide a visual description of your building and office. This can reduce patients' stress related to orienting themselves. You can just use clear descriptors such as straight ahead and on the right. The desk is 5 feet to your right. Avoid vague descriptions such as over there or go that way. Number four, step four is to take time to self-reflect. Best practice D is discuss. Discuss with your peers, your supervisors about emotions, inclinations, and biases that you may have that could be impacting the therapeutic relationship. To identify countertransference. So ask yourself, what if I became blind? Do I know anyone who's blind? Do I have misconceptions about blindness? So those are the ABCDs of the content that Dr. Hills has provided. We have some book recommendations and we will be sharing the slide deck afterwards. So all of the recommendations are listed on this slide. It includes The Beauty of Dusk, The Wounded Storyteller, Unmasking Autism, Their Plant Eyes, A Personal and Cultural History of Blindness, Eavesdropping, A Memoir of Blindness and Listening. Again, you will receive this afterwards. And then we have a reference slide for all of the good content and where you can learn more. And then on the second to last slide, we have 2 QR codes. The one on the left is for the Aspect program to learn more about that. If you think any of your clients or yourself would like to join, we're accepting a new cohort in the spring of next year. And on the right is the mental health issue brief that I mentioned. It's a QR code. You can scan it to be taken to the webpage at Prevent Blindness, where we have all of the recommendations and the summary of all of the discussions from the Mental Health Task Force. We want to thank you so much for attending and for staying on, even though we have gone late. We appreciate it so much, and we are so grateful to finally be able to reach the audience we've been wanting to talk to. And so we are open to any questions and feedback for going forward. I know we don't have time to address them at this moment, but you can please email me, Julie, and my email address is J, and that's Gritzmacher, my last name. That's G as in good, R as in rose, U as in until, T as in tree, Z as in zebra, M as in mother, A as in apple, C as in cobbler, H as in her, E as in elephant, and R as in rose, at preventblindness.org. So that's a mouthful. But Jay Gritzmacher at preventblindness.org, please email me with any questions and I can share them with Dr. Hills and Dr. Pouliot as well. Okay. And this time I'll turn it over to Kati to close us out. Oh, and Kati, do you want me to share my screen again to go through the rest of the slides?
Yeah,
Yeah, okay. 1 second.
thank you. It's on the evaluation slide. Next slide.
Okay.
Thank you so much. And thank you so much for presenting and providing us with a wealth of information on this topic. Thank you, Julie. Thank you, Sharon. Thank you, Connie, for being so open and candid about your experience, as professional experience, personal experience, and providing us with an overview on different techniques and different approaches to help people who have blindness or low vision. In the chat, I shared a link to our evaluation survey. If you could please complete this survey, it really means a lot to us to know what your perspectives are and your feedback. And then it's easier for you. You can also scan the QR code that you see on your screen. Next slide, please. And as a reminder, we will email everyone a certificate of completion as well as a link to download the presenter slides and view the recording. Next slide, please. And again, I just want to thank you all for staying with us. I know we went a little over and we didn't get a time for questions, but we have shared the email addresses for Julie in the chat, so you can contact her directly if you have any questions. And we want to thank you as well for your active participation and your feedback. We hope you will join us next time for our future training sessions, and we hope you have a wonderful rest of your day. Thank you, everyone. Bye-bye.